understand. You can understand that 1.9 million cells every minute accounts to several thousand cells per second. So if we are able to open up these blood vessels by some way, then this potentially damageable area, which is the penumbra, can be prevented and the patients can have a significant recovery from the ischemic stroke. So this is the thrombus, which is the red area. The area which is just around this blocked blood vessel in light whitish beige color is the infarcted zone, and this dark zone around this is the penumbra. So our idea is to salvage this penumbra as much as possible. So this is the mathematics. You can understand that as soon as the blood vessel is blocked, there is every second that there are changes happening inside the brain. And that is why we call time is brain. So as soon as the blood vessel is blocked, within the few minutes, there are excitotoxicity chemicals which are being released. There is a peri-infarct depolarization happening at the cellular level. As soon as the cell dies, there is inflammation which develops all around it, which causes a cerebral edema. And over several hours, this inflammation tends to swell, and sometimes it can cause significant amount of cerebral edema, which might require surgery. Over a period of time, this inflammation settles down over several days, and then there is the gradual apoptosis and ingestion of these cells, and that causes gliosis and eventually loss of volume of the brain. So every stroke, the neurons lost are about 1.2 billion. Per hour, it's about 120 million. Per minute is 1.9 million, and per second, 32,000. The number of synapses which are lost in this process are immense. You can understand this is more than the total population of the world. So every second, there are 230 million synapses which are being killed. And every second, about 200 meters of the myelinated fibers are being lost. And every second, a patient ages by 8.7 hours if it is not treated adequately. So you can understand this magnanimous mathematics, that how important every second is in terms of identification of stroke. So why is it all important? Because the benefits of only approved drug for acute ischemic stroke are highly time dependent, and therefore it is undoubtedly the important thing to be told that one has to develop a system to minimize the delays in administration of these thrombolytic agents, which might be alteplase or tenecteplase. So how do you recognize a stroke? That is the simplest of one, but one has to remember. So sudden numbness or weakness of one side of the face, arm, or the leg. There is sudden confusion, trouble in speaking, or difficulty in understanding, sudden trouble in seeing in one or both the eyes, and sudden trouble in walking, dizziness, loss of balance, or lack of coordination. So these are very simple things, and the mnemonic for which is fast. So if you have a facial asymmetry, you feel that the face is swollen or is fallen on one side. If you find that the arm is not moving on one side, or there is a droop when you ask the patient to elevate the arm, if there is a slurring of speech, this is the time to act. So face, arm, speech, if they are involved in any sense, even if it is not a stroke, consider that this patient has a stroke, and this is the time to call the emergency and rush to a hospital where stroke can be treated. So this is again the same thing: facial droop, arm drift, and speech. So as I already told you, there are two types of stroke, the hemorrhagic and the ischemic. Now the point is that in hemorrhagic stroke, you don't have to do much. You have to do only a hemodynamic stabilization. You have to manage the blood pressure. And if the bleed is large or is causing compression over the nerves or the brain, then you have to evacuate this. So surgical intervention is required in some cases. But it's the ischemic stroke where you can do a lot. And as I've already told you, that the first hour of the treatment is the golden hour in which the deficits which happen eventually can be minimized significantly. So within first 4.5 hours, if you are able to reach to a stroke friendly or a stroke ready hospital, then these clot buster treatments can be offered to these patients, and they will have a significant improvement. So if the patient has had a stroke and he reaches to a hospital within the first 4.5 hours, then these patients can be offered thrombolysis, for example, with alteplase or tenecteplase. If the patient has a larger stroke, if a larger blood vessel is blocked, then we can go inside the brain we can reach directly up to the artery and we can suck that clot out and open up these blocked blood vessels. So both these things can be given to a patient depending upon his requirement, but the most important thing is that the patient should be reaching to the hospital as soon as possible. So, a stroke center, which is a stroke ready center, should have an organized protocol for emergent evaluation of suspected stroke. There should be a designated stroke team, and there should be a system in which alteplase or tenecteplase should be given to the patient as soon as possible. And there comes the importance of what we call as a door to needle time. So the primary goal is to achieve a door to needle time of 60 minutes or less in less than 50%, in more than 50% of the cases, and preferably 45 minutes or less in 50% of cases if it is possible. So this is what we call as the door to needle time. So door to needle time is the time which is taken between a time when the patient arrives at the emergency room and is given the injection of a clot buster. So this door to needle time should ideally be less than 60 minutes. We try to achieve a door to needle time of less than 30 minutes. Now, this is the time period which is the most important in terms of management of acute ischemic stroke. So what are the quality indicators? So door to needle time should be less than 60, and door to puncture, which means you take the patient to the intervention suite, you do a DSA and you suck the clot out. So that time should be less than 90 minutes. At our center, we are crazy about management of stroke, and we ensure that the door to needle time in no case should be more than 45 minutes. It should ideally be 30 minutes. And there have been times where the patient has been punctured and the blood vessel has been opened up in less than 60 minutes. So that is what we should aim when we discuss about the excellence of a stroke center. So this is why, because this is the golden hour. So when a patient at home is suspected to have a stroke, within 10 minutes of arriving to the hospital, a doctor should be able to evaluate the patient. Within 15 minutes, the stroke team should be told that a stroke patient has come. Within 25 minutes, a CT scan should be done, and the results should be interpreted, and the treatment should be administered in the first hour itself. So that is an ideal way of management of an acute ischemic patient. But what are the problems? So first is patient identification, that is has stroke. Then there is a problem of registration of the patient, the payments, delivering the patient to the emergency room, putting in an IV, putting in a monitor, vital signs monitoring, lab testing, blood glucose evaluation, estimating the patient's weight, history taking, medication assessment, evaluation of the clinical condition of the patient by a neurologist, what tests one has to do, the imaging of the patient, and during imaging, we need an MRI, we need a CT angio, we have to prepare the TPA and the injection, and then we have to infuse. So this is a humongous task. But if you manage your emergency well, then these things can be very easily achievable. So how do we do it? We do it. There is no patient registration required. As soon as a patient with a suspected stroke is told, within few minutes, the patient is seen directly by a neurologist, even sometimes before the emergency doctor sees. There are no forms to be filled. There are no tests to be done. The patient is wheeled straight into the CT room. The CT is done, and the patient is administered sometimes TPA right in the CT room. We don't do the tests first. We don't look at the PT. We don't look at the INR, because these are all relative contraindications. The most important part is administering the clotbuster treatment as soon as possible. So this is how we tend to have a complete code stroke. As soon as a patient with suspected stroke comes, there is one number which is dialed, and these 7 people, they receive the immediate information that a stroke patient has come, and this whole team is triggered into action as soon as possible. I think somebody is.
Dr. Pawan, can you mute Dr.
Mute all.
Hardeep?
Except Dr. Sumit.
Yeah. So
Dr. Pawan,
these are
please mute everybody except Dr. Sumit.
सुमित सिंह ही कर पाएंगे सर, मैंने उनको होस्ट बना दिया।
अच्छा, छोड़िए, चलिए, खैर अपने आप को म्यूट कर लीजिए जो भी कोई। So this is how we basically tend to have a timeline drawn. So this entire things happen in less than 2 to 3 minutes of arriving a patient into the emergency room. So this is what I am trying to give you an example. So when there is a Formula One racing, within a few seconds, you can see that 12 or 13 people are involved in changing all the four tires and putting in new tires. And this all happens in less than a minute. So in similar fashion, there is a complete stroke team which is activated in a stroke center. And these all people know that what is their role. They all know what they have to do. They will do only that part and nothing else. And that is why when everybody is assigned a particular role and the person does that role, then obviously these things, they are being taken care of in a better way. So this is basically a stroke team. It involves a neurointerventionist, the ER, the laboratory, the radiology, a neuro nurse, a stroke nurse, ambulance, rehabilitation, and a neurologist who's supposed to be the stroke champion. So, why is it important to identify stroke? Because if we don't act fast, we will lose brain. And I told you that the volumes of cells lost are more with increasing time. Therefore, early recognition of stroke symptoms is undoubtedly the most important aspect. And this is where the importance of us doctors comes in public education. And this initiative probably is a good part in that line. There is also a requirement of stroke networks. So there should be a center of referral, and those people who are able to identify the stroke, they should ship the patient as soon as possible to a stroke ready hospital if required. There should be prioritization and direct transfer to specialized stroke centers. And this stroke center has to be managed by a multidisciplinary team. And that is where the role of identification of stroke comes into the play. And this is basically to educate the people that if you have any of these four signs, you should come to a hospital as soon as possible. So once the patient comes in, there are several type of treatments apart from the main treatment, which is thrombolysis. So we give the patient thrombolytics if required, if he comes within the window period. After the window period is over and the infarct has been established, there is only general supportive care, management of acute medical complications, giving the patients antiplatelets or anticoagulants depending upon their requirement for prevention of further stroke, management of acute neurological complications which might arise because of the stroke, for example, seizures, hemorrhagic transformation, cerebral edema, which might require decompressive craniectomy, and of course, intensive care unit where stroke patients can be managed for this aspect of treatment. So I've already told about thrombolysis, and I've already told about other aspects of treatment. So these basically tissue plasminogen activators, what they do is that they tend to decrease the activation of clot formation, and whatever clot is present, it tends to dissolve that particular clot. So there are several trials. I will not go into the details of those trials, but today, in the first 4.5 hours, the treatment by thrombolysis in a patient with acute ischemic stroke is the standard of care. And those patients who have large vessel obstructions, thrombectomy or clot retrieval is also a standard of care in tertiary or quaternary level centers. So I think every patient who has any ischemic stroke should be offered a treatment with thrombolysis. What are the contraindications? All these contraindications are relative. The only absolute contraindication is a patient who has had a bleeding, a major operation within the first few weeks, or there is a definite evidence of some bleeding in some part of the body. Apart from that, almost all these indications are relative contraindications. So the idea is as simple as that if you have a patient with stroke, if you find that the CT is not showing any hemorrhage, just go ahead and thrombolyze it. And when the patient is being thrombolized, he should be shipped to a center that in case he requires a thrombectomy, then it can be offered to these patients if required. And that basically brings me to the conclusion of my presentation. So as I already told you, that identification of a problem is solving the problem by 50%. So in our society, weakness of one side of the body is not considered as important. chest pain is considered as extremely important thing, and this requires a very active treatment. But unfortunately, the weakness which is going to evolve after a ischemic stroke is going to be disabling. Therefore, identification of the symptoms of stroke are extremely important. उस टाइम पे कबूतर का खून नहीं लगाना, उस टाइम पे खरोड़े का सूप नहीं पीना, उस टाइम पे हाथ को चलाने की कोशिश नहीं करनी. At that time, the only and only thing which can help you cure yourself or prevent yourself from having a disability is to rush to the nearest possible hospital, to tell and imbibe into the minds of the treating physicians that thrombolysis can be offered anywhere. It does not require a very specialized or a high end center. But once the thrombolysis is initiated, it is best that the patient is shifted to a area or to a hospital where a stroke unit is established. Thank you very much for your kind attention.
Thank you, Dr. Sumit. Such a nice talk, such a simple manner. Just want to have your comments. As you have already told that there is a heavy burden of the stroke, almost 3,000 strokes per day in India. And what preparedness one of our friend can keep at the smaller place and in their smaller hospitals? Because number of stroke ready hospital, as you are mentioning, that is a rarity. We are fortunate enough that in Gurugram we have several units, and of course yours one is the best one. But we have many other places where our medicine friends are working. So what type of some you can say partnership you can look forward with
Very,
the
very good question, sir.
yeah
It's an extremely good question, sir.
yeah.
So the what is important is that any hospital which has a CT scan can do thrombolysis. Now, there are two types of thrombolytic agents. One is alteplase, the second is tenecteplase. So tenecteplase is even more important because what it can do is that you only give one single injection in a single bolus. Alteplase requires 10% to be injected as bolus and less 90% to be injected as an infusion. But tenecteplase can be given as a single injection, and it is almost 3 times cheaper also as compared to alteplase. So any hospital which has a CT scan, you find that the patient has got a normal CT or a CT in which there is no hemorrhage. You keep injection tenecteplase, you give that injection straight away and send the patient to a stroke ready hospital. So what we have done is that we have tied up with several hospitals across Haryana in a spoke and hub fashion, in which we have tied up with these people, and there are actually apps which are available, and we have given to these hospitals that as soon as you get a patient, you inform us, load the images of the CT scan on that app, that information will come to us, and we can prepare our hospital in case we need any advanced treatment.
That is good, Dr. Sumit. But I am, of course, you are already doing it. But can you offer some small courses like for the stroke, for the doctors, physicians, as well as for the nursing staff also?
Absolutely.
So
We
I
can do
think
that.
that can be of great help, and we can look forward for it if you can just make something, some courses like that.
Yes,
So
okay.
can circulate it
We
to
will be
our
more than happy to do that. I will be sharing you the module, and you can circulate in the centers who have some sort of facility at their place. And if anybody wants to have an online discussion or want to have an online training course, that also we can organize whenever required.
Thank you, dear. Thank you so much.
Right.
But to Dr.
Hello.
Sir, Dr. Ramesh Goyal, sir.
I want to share one of my experience, recent experience, though Dr. Sumit is saying same thing for many years. अभी एक पेशेंट 3 महीने पहले मेरे पास स्वीडन में उसको स्ट्रोक हुआ, वो अपनी बेटी की डिलीवरी के लिए गया था, 70 year old. उन्होंने वहां पे हेल्पलाइन को फोन किया, दे हैव शिफ्टेड दैट पेशेंट टू बाय हेलीकॉप्टर इन देयर सेंटर, और उसका विद इन 40 minutes उन्होंने स्ट्रोक को जो भी इंटरवेंशन करना था, जैसे डॉक्टर सुमित ने बताया, कर दिया। और वो 5वें दिन इंडिया डायरेक्ट एयरपोर्ट से मेरे पास शिफ्ट हुआ। उसके लेफ्ट साइड पूरी हेमीपैरेसिस थी, बैठ भी नहीं पा रहा था। लेकिन 1.5 महीने या 2 महीने के बाद या थेरेपीज के बाद वो 6 फ्लोर की सीढ़ियां चढ़ के गया है। मतलब दैट इज इम्पोर्टेंस, जो मेरे को पहले रियलाइज नहीं होती थी। मैं तो पहले जैसे एज 11 भी स्ट्रेप हो गया तब तो गया। मतलब आप मैंने ये ट्रेमेंडस इफेक्ट 1.5 महीने के थेरेपी के साथ, जो उनका इंटरवेंशन था 40 मिनट्स का, उसने हेलीकॉप्टर से उन्होंने वो लेके गए और एयरपोर्ट से सीधा मेरे पास आया। तो मतलब तब मैंने देखा कि इट्स वेरी इंपॉर्टेंट। जैसे हमारे हार्ट में कोरोनरी आर्टरी ब्लॉकेज होता है, द सेम वे intervention is affected, and very important time management. So
एब्सोल्युटली
I, you must be seeing so many patients, but मेरा फर्स्ट हैंड एक्सपीरियंस जो अभी लेटेस्ट बता रहा हूँ आपको।
सर, हमारे साथ भी ऐसा हुआ था। फरीदाबाद में ही एक इंटरवेंशनिस्ट हैं जो पहले अपारस में थे। तो उनकी मदर को स्ट्रोक हुआ था, एंड दिस हैपेंड व्हेन ही हैड अ फ्रैक्चर ऑफ हिज आर्म। तो डिस्पाइट बीइंग अ इंटरवेंशनिस्ट, ही कुड नॉट डू इंटरवेंशन फॉर हिज ओन मदर, क्योंकि उसका हाथ में फ्रैक्चर हुआ था। तो ही रेफर्ड द पेशेंट, एंड ही स्टार्टेड एट say 8:30 from Faridabad. They ran through an ambulance. They reached our hospital say at 9. At 9:15 we had punctured and opened the artery. So the point is identification of the symptoms and action as soon as the symptoms start. वो लोग बाग बैठे रहते हैं ना, मालिश करेंगे कुछ। हमारे यहाँ तो बहुत इंपॉर्टेंट है कबूतर का खून, खरोड़े का जूस, वो
कंप्यूटर को
पिलाएंगे,
पकड़ के
गर्मी आ
लाते हैं
जाएगी,
पहले।
खून बढ़ जाएगा। सब जगह चले जाएंगे डॉक्टर के अलावा। दैट इज द बिगेस्ट पार्ट।
नहीं, मैं तो ये मतलब मुझे तो वाकई मतलब बीइंग ए डॉक्टर आई वाज नॉट अवेयर ऑफ दिस फैक्टर। मैं आपको फैक्चुअल सिचुएशन बताऊं।
सर, वी डू अबाउट 2 to 3 थ्रोम्बेक्टमीज इन अ वीक। जो हम थ्रोम्बोलिसिस करते हैं वो तो प्रैक्टिकली डेली 1 या 2 हो जाती हैं, बट जो हम क्लॉट रिट्रीवल की बात कर रहे हैं, विच इज द मोस्ट एडवांस ट्रीटमेंट टुडे, वी आर डूइंग 2 to 3 इन अ वीक।
सर, डॉक्टर सुमित सिंह सर, एक क्वेश्चन मेरा भी है।
जी सर।
सर, बेसिकली बिफोर गिविंग दिस thrombolytic therapy, should we try to rule out stroke mimics also? And what
एब्सोल्युटली,
stroke mimics should be ruled out, because it is really very, very, very important.
एब्सोल्युटली सर, मैंने सबसे पहले वही बताया कि यू हैव टू रूल आउट स्ट्रोक मिमिक्स, बट द पॉइंट इज वेस्टेज ऑफ टाइम। आप अगर जो किसी पोस्ट सीजर वाले पेशेंट को थ्रोम्बोलिसिस दे भी दोगे, कोई फर्क नहीं पड़ेगा। द ओनली थिंग यू हैव टू रूल आउट इज सबरेक्नोइड हेमरेज, you have to rule out tumor bleed, you have to rule out intracerebral hemorrhage. That is the only thing you have to rule out.
And what
Even
about
if a,
hypoglycemia, sir? Very
that's what I'm saying. So
simple test.
see, blood sugar takes 30 seconds.
Yeah, yeah.
Blood sugar takes 30 seconds.
That was the message I wanted to convey to
Yes,
almost everybody.
absolutely. So ये तो मैंने बताया था कि ये 3 मिनट में, पहले 3 मिनट में ये टेस्ट हैं जो हो जाने चाहिए। अगर जो वो टेस्ट में मान लीजिए शुगर आपकी 10, 12, 15 आती है, तो दैट मीन्स इट्स अ स्ट्रोक मिमिक। You will first give glucose and then think about thrombolysis.
Sir, some more questions for my.
I will want to ask question.
Yeah.
सर, जैसे ये हार्ट अटैक है, ये अब धीरे धीरे शिफ्ट हो रहा है, मतलब 20-25 वालों का भी हो रहा है। क्या स्ट्रोक में भी ऐसे ही हो रहा है कि वो धीरे धीरे यंगर एज ग्रुप में हो रहा है?
Yes.
या
Absolutely.
बच्चों में भी हो सकता है?
Post stroke, post COVID, I think there is some problem which has developed in the coagulation parameters of patients, whether it is because of the COVID or it is because of the vaccination. But there is something which is definitely happening at the coagulation cascade. Younger patients are coming with MI, younger patients are coming with stroke. No doubt about it.
सर, बच्चों में भी किसी में देखा 18 साल से नीचे?
हाँ सर, बिल्कुल देखा।
Hyperhomocystinemia is one important cause.
Yes.
And basically accessories arteries or some aberrant arteries, they could also be one of the causes.
Cardioembolic is also possible in children.
Cardioembolic is also possible. Sir, for the benefit of my audience, I would also like to ask some more questions.
Sure.
Sir, what about the BP management in stroke? Because
Yes,
there was a practice and still it is there in some of the centers, that whenever the patient comes with BP of 200, 120, they first of all they give capsule dipin sublingual, which causes a precipitous fall in blood pressure, and it is really detrimental to the neurological outcomes.
Absolutely. So this should never be done. The high blood pressure is never a problem in patients with ischemic stroke. This is because a high blood pressure keeps the brain perfused at least from those blood vessels which are at least opened up. A high blood pressure tends to open up the collaterals which are latent or which are sleeping. So those collaterals are opened up. So in patients with ischemic stroke, a systolic blood pressure of 180 or above, a diastolic blood pressure of 110 or above. Basically, we have to keep the mean arterial pressure less than 150 or 160. That is our target. We never ever overtreat hypertension in ischemic stroke. In patients who have hemorrhagic stroke, it has been observed that the management of high blood pressure should be more aggressive, because it has been observed that in the first 6 hours, the size of the bleed has a potential to increase. So in hemorrhagic stroke, one has to be more aggressive and to bring down the blood pressure to as low as normal, which is possible, and as soon as possible.
Sir, one more.
Dr. Sumit,
Yeah.
is any correlation of the epileptic fit between in younger age stroke, 18, 20-year age?
No, sir. We never give prophylactic anti-epileptics to any patient with
No, convergence is possible
stroke.
after that.
In embolic stroke, the risk of convergence is higher. In non-embolic stroke, the chances of convergence are less. Venous strokes are more likely to have epileptic attacks associated. Arterial strokes are less likely to have.
So one more frequent mistake which is being done in the periphery is whenever a patient is suspected of stroke, usually the clinician orders for an MRI, which takes a long time. So your message, whether CT or MRI?
Absolutely right. So it depends upon where the patient is being seen. What we do is we do only MRI. We do diffusion restriction, we do flare sequence, and we do the ADC sequence. So this entire MRI takes about 3.5 to 4 minutes. Then we do an MR angio TOF, time of flight imaging. So that requires another 1.5 to 2 minutes. So within first 7 or 8 minutes, our complete imaging is over. So this is for a stroke ready center, because we have to decide whether we are going in for thrombolysis or we are going in for thrombectomy. At a periphery, I think the only thing which should be done is a CT scan. And if you find that the patient does not have hemorrhage, start thrombolysis and refer to a center where further advanced treatment can be offered.
Sir, also a word about antiplatelet therapy, whether DAPT or single antiplatelet.
Yes, very good. So I think these are the golden questions which you are asking, and that is expected from you, sir. So the double antiplatelets is a rule of treatment for acute ischemic stroke, except in 2 or 3 conditions. One, when you find that the stroke volume is extremely large. So which means that if the size of the stroke is more than 1/3 of the hemisphere, in those cases, you should start only with a single antiplatelet. If you find that the size of the stroke is less than 1/3 or equal to 1/3, in those cases, you should start with double antiplatelets. Also, it is important that you should start with high doses of statins. So these high doses statins, they have a membrane stabilizing effect. So in case there is a sort of a ruptured intima or a ruptured plaque in any of the blood vessels, that plaque is going to stabilize, and the chances of embolization from that plaque are going to be minimized. If a patient has a very large stroke, say if you feel that whole hemisphere is being gone, in those cases, we give only single antiplatelet, because there is a possibility that this patient might require surgery. If he's on double antiplatelet, surgery cannot be offered. Also, it is important that if a patient has atrial fibrillation, in those cases, we should not give the antiplatelets. We should straight away start with anticoagulants, again, depending upon the size of the stroke. Also, it is important that if a patient has been thrombolized, we start the antiplatelets only 24 hours after the thrombolysis has been done.
Thank you, sir. Thank you. If anybody has any other question, he can unmute and ask the question. Dr. Taneja, sir.
सर ये जो अटोरवास्टैटिन बताइए आपने, जैसे 80 mg सर स्टैट जैसे दे सकते हैं, जो हार्ट अटैक होता है, हम सस्पेक्ट करते हैं तो 80 mg स्टैट देते हैं, वैसे इसमें भी दे सकते हैं?
एक्चुअली जो ब्रेन के ब्लड वेसल्स हैं, दे आर अ लिटिल मोर फ्रेजाइल देन द कॉरोनरीज, सो वी प्रेफर गिविंग अराउंड 40 milligrams. If a patient is markedly bulky, say around 75 kilograms or more, then we give 80 milligrams.
सर एक और मेरी थोड़ी रिक्वेस्ट रहेगी आपसे, पता नहीं वो सही है या नहीं है। सर आपने नाम लिया कि या तो कोरोना से हुआ है या उसकी वैक्सीनेशन से हुआ है, तो उसमें सर मेरी थोड़ी सी रिजर्वेशन है कि हमें मतलब वैक्सीनेशन को ब्लेम नहीं करना चाहिए।
आई एम नॉट ब्लेमिंग सर, आई एम जस्ट फाइंडिंग एन ऑब्जर्वेशन. मैंने ये बोला ही नहीं,
वैक्सीनेशन का
मैंने
सर
बोला
नाम
आई
नहीं
डोंट
लेना
नो
चाहिए।
वेदर इट इज बिकॉज ऑफ कोरोना और द वैक्सीनेशन, आई डोंट नो, but what I have observed is an increase in the number. It could be that corona has changed the coagulation cascade. How do we know?
सर क्योंकि जितने कोरोना के एक्चुअल में हुए थे उससे पर कई गुना सर ऐसे थे जो एसिम्प्टोमेटिक थे, जिन्होंने कभी टेस्ट नहीं करवाया, उनको कोरोना हुआ। उनको वैक्सीनेशन का तो याद है, हमने वैक्सीनेशन करवाई थी। एसिम्प्टोमेटिक कोरोना भी हुआ था बहुत सारे लोगों को। कोरोना की डोज तो सर फिक्स्ड है, मतलब वैक्सीनेशन की डोज तो फिक्स्ड है, अभी 2-3 दिन में क्लियर हो जाएगी। कोरोना होगा तो अरबों खरबों, मतलब कि वो उसके अंदर वायरसेज होते थे जिनकी कोई लिमिट ही नहीं होती थी। तो ये अगर प्रेफरेबली मतलब वैक्सीनेशन को नाम ही ना लेते तो सर ठीक रहेगा, सिर्फ
नहीं,
कोरोना
मैं
सर
नहीं
आप
बोल
पार्ट है।
सकता ना. See, no, if we don't know, we have to say that we don't know. I'm not blaming it on the vaccination. I'm not blaming it on corona either. I'm just saying this is an observation. I am not at expertise to say whether it is because of corona or because of vaccination.
Good evening,
Thank you,
sir.
sir.
Dr.
Good evening, sir.
Yes.
Yes, sir. Sir, I'm Dr. Akhil. I have passed out from my MBBS in the year of 2023, and currently I'm preparing for my NEET PG exam, sir. So after passing out, I used to work in a small PHC, sir, in a village. So over there, sir, with limited resources, how can I assess the situation? What can I do to prevent strokes, sir? So,
You
sir,
can
can I give a oral anticoagulant, sir,
no,
in
no,
such settings?
no. Previously, there were scores in which we tried to identify that this patient might have a hemorrhagic stroke, this patient might have a ischemic stroke. But now those scores, those parameters are all obsolete. We have a CT scan available which can identify it in minutes. So why should we do the scoring? So, at a periphery where no resources are available, it is best to refer the patient as soon as possible to the nearest tertiary care center. That is the best which you can do. There is nothing else which can be offered at the PHC level for a stroke.
Okay, sir. Sir, one more doubt, sir. Sir, like the stroke occurs because, like one of the causes for stroke is because of the hypercoagulable state, right, sir? So it's mostly associated in early mornings, right, sir? What is your comment about that, sir?
Yes.
So how to prevent hypercoagulable states in the first place?
No. See, the hypercoagulable state is a multifactorial problem. So hypercoagulation could be because of genetic abnormalities like protein C abnormality, protein S abnormality, then antiphospholipid antibody syndromes or vasculitis or certain genetic abnormalities. They could be because of hyperlipidemia, that could be because of hyperhomocystinemia, that could be because of diabetes, that could be because of smoking, alcohol. So these are all factors which join together to create a hypercoagulable state. So you have to address each and every one of them to bring down the hypercoagulable states to a minimum. But these should not be treated unless identified. So prophylactic ecosprin or prophylactic aspirin is not to be offered to patients, even if they are at a high risk of stroke. So their risk factors should be modified, but treatment, this was evaluated in what we call as a multiple risk factors intervention trial, in which patients were offered prophylactic aspirin, and it was found that symptomatic and asymptomatic intracerebral hemorrhage was much higher in the treated population as compared to the non-treated population, and this trial had to be actually stopped in between because of the side effects which happened in the form of intracerebral hemorrhage. So prophylactic aspirin is going to do more harm than treatment after the stroke has already happened.
There was
Okay,
an
sir.
increased risk of GI bleed and mortality.
Yes, both were high.
Okay, sir. So the best thing is that if a patient comes with fast symptoms, you have to refer it to the higher centers for further
Yes,
management.
if you have a CT scan, you can safely thrombolize at your center.
Okay, sir. Sir, I have one more request, sir. How can I attend such CME, such informative CMEs, sir? Because
You are already attending. This is the best one.
no, sir. Yes, sir. But I want to attend more such CMEs, sir. I'm just a very young graduate doctor, sir. So because like in my PhCs in such situations, if I get to know how to counsel the patients in the periphery, it will be very helpful, sir. So these CMEs are
I
very
wish we had
useful.
more energetic people like you. Today's students, unfortunately.
Dr. Karan Juneja, please take care.
So on every Thursday, we are having a CME on varied topics, and probably Dr. Akil, you can join our this talk every Thursday, 8:30 p.m. to 9:30 p.m. for the
Okay.
whole year 2025.
Okay, sir. Sir, like apart from Thursdays, any other time like where I can attend more CMEs, like your like should I be added to any WhatsApp group or Telegram group for
No.
such more
I
updates?
hope Dr. Akil is a IMA member.
Sir, I've applied for not IMN member, JDN member. I have applied only last 3 to 4 days back, sir.
Then you talk to Dr. Karan Juneja. He'll help you out.
Oh, okay, sir. Sir, can I have his contact information like email ID or WhatsApp number?
Dr. Karan.
आप इनको प्राइवेट मैसेज भेज दीजिए एक.
हाँ, yes, sir.
Okay.
Good evening, Dr.
Yeah.
Hello.
Dr. Malik.
Good evening. Good evening, Dr. Pramila Malik here. Excellent presentation, Dr. Sumit.
Thank you,
I
ma'am.
just wanted to ask how to recognize TIAs, transient ischemic attacks, so that we can prevent the stroke.
Yeah, so that is what is fast. Facial asymmetry, acute
Okay.
weakness on one side of the body, or change in
Okay.
speech. If you have
Okay.
any of these three, imbalance in walking, sudden severe headache,
Okay.
anything which happens like this, you should first consider stroke.
Okay. And secondly, I just wanted to comment that hyperhomocystinemia is very common in Indians.
Yes.
That should be taken care of.
Yes. So
And both dietary and that MTHFR deficiency. So
that
it's a
is
very
one.
common cause.
Predominantly, it is dietary. Predominantly, it's dietary. If you look
Yeah.
at the
And it's
MTHFR
a very
mutation,
easily treatable cause.
absolutely, ma'am. So
Yeah.
MTHFR mutation is seen in less than 3 to 4% of cases. It is mostly
Yeah.
dietary.
Yeah.
So the
Yeah.
three main vitamins which one has to look for is folic acid, vitamin B12, and pyridoxine.
Yeah.
So these are the three things one should be careful about.
Yeah. Thank you.
Dr. Jain, Dr. MP Jain.
And
Yes,
it's
sir.
a
Yes,
very,
sir.
very
सर
good
आप
initiative. I must
सर आपने बहुत
congratulate the
अच्छा शुरू
IMA.
किया सर ये इसको मैं कहूंगा वेब सीरीज है सर ये
Thank you, sir.
हेल्थ
Thank
वेब
you.
सीरीज
Yes, I must really congratulate Dr.
वो
MP Jain.
कोरोना समय की याद आ गई सर जब मैं तो एएमएस का चेयरमैन था उस समय
बहुत ही
और भी
अच्छा है ये. And
वेबिनार किया
prevention
करते डॉक्टर
and
पवन गोयल भी
preventive
किया करते
aspects
काफी
is
तो
Dr. Sumit? Two things, sir. We had a lot of experts with us in Haryana. And once the technology is available, why not to benefit all the members, sir? And especially, we are thankful to all of you, those who have spared the time and joined this program. And just one more request to each of you, just circulate the message of these CMEs to your local groups, other groups, your friends, so that more and more people can join and can be benefited. Thank you. Thank you so much. Thank you, Dr.
सर
Sumit.
इसको आप यूट्यूब पे फिर अपलोड भी कर सकते हैं सर
Hello,
तो
Dr.
जो लोग
Dr. MP Jain, I must congratulate you for starting this series.
Thank
It's
you,
a very
ma'am.
good initiative.
Thank you, ma'am.
सर इस वेब सीरीज को सर आप यूट्यूब पे भी
Yeah.
अपलोड कीजिए सर
हाँ
And
वो
we
है
should-
sir वो now we are doing that also. We are
Just-
making a YouTube channel of IMA Haryana
very
and
good.
everything will be uploaded there.
Yes.
And one
Yes.
more comment I just wanted to say कि we should make some programs for public awareness also, for general public awareness in Hindi, in YouTube.
बिल्कुल कर सकते हैं.
So that will help the general public also.
Ma'am, that is already in proposal and that will be done in a very, very short time.
Yeah.
What
That's
what I
great.
can suggest is that जैसे अभी मैम ने बताया, कविता मैम ने, जो डिफरेंट डेज होते हैं उस पे अगर जो हम पब्लिक को भी इन्वॉल्व कर लें तो वो बहुत अच्छा होगा। जैसे स्ट्रोक डे है, एपिलेप्सी डे है, पार्किंसन डे है, हियरिंग डे है, उसमें
That can be done. That can be done, Dr. Sumit. It's a nice suggestion, and definitely we can promote that. Let us start somewhere, and let us see to it where what the response we get from the public. Definitely. Thank you.
Thank you very much for a patient listening, and it was a deep honor to be present with this August gathering. I'm really honored. Thank you.
Thank you, sir.
Thank you.
Thank you, Dr. Sumit.
Thank you, sir.
Okay, good night,
Now I
everybody.
would request
Thank
Dr.
you.
Kavita to post a thank you message for us. Dr.
Yeah. It was an honor to receive Dr. Sumit Singh today, and since I'm an ophthalmologist, it's just a revision of all my MBBS days, I must say. But there have been stroke cases in my own family, so I know a little about the subject. And it was very nice to see the younger generation too, who was just 23 pass out MBBS person, and also our seasoned doctors over here. And I'm really thankful to Dr. P.JAIN sir to start this academic journey, and Dr. Pawan Goyal is taking good care of all the lectures. And we hope to meet you every Thursday. And till then, thank you so much. Goodbye.
Ma'am, good evening, ma'am. Ma'am, can you add me to such, introduce me to such more informative CMEs?
Sure,
ma'am?
sure. You can get in touch with Dr. Karan Juneja, and he will add you to all the groups where we will be posting our messages. Okay, he's already in touch with you. Okay.
Oh, okay, ma'am. Thank you very much, ma'am, for this opportunity.
Okay, good night, everybody.
Okay, sir. Thank you so much. Good night.
Thank you. Good night, everybody. Thank you so much.
Good night, sir. Good night. 3 ophthalmologists are there in this group right now.
Sir, एक question,
अब आफ्ता की टॉक करनी पड़ेगी जल्दी।
मैं भी करूंगा एक वैक्सीनेशन के ऊपर।
हाँ जी डॉक्टर, जरूर
है सर, वैक्सीनेशन पे हमारा टॉपिक है, तो उसमें
अच्छा जी।
डॉक्टर पवन गोयल इज एक्चुअली ऑर्गेनाइजिंग एवरीथिंग, जो वो कहते हैं वो हम कर देते हैं। ठीक है,
ठीक है।
थैंक यू मैम।
ओके जी, गुड नाइट।
ओके, बाय बाय।
थैंक यू एवरीबॉडी,
Good
गुड
night.
नाइट, गुड नाइट, गुड नाइट।